will have a severe symptom with difficulty of breathing, and which can, some patient can recover, but some other will get complication that can cause death. The determinant factors is the virus itself, the amount and the virulence, and the body strength, immune system, nutrition, and exercise. This is the diagram. The virus enter the cells through the receptor ACE2, then it replicates inside the cells, and then viral shedding. This grow and replicates needs time. The body will respond by producing antibody, IgM, IgA, and IgG. The time and length of detectable antibodies differ among people, but usually the IgM starts on the day 7 and IgG, IgA shortly afterwards. From this diagram, we can see that antibody test is not proper for diagnosis, but especially for history of exposure and immunity. Now I would like to show some slides about situation in Indonesia. This is Indonesia, and the capital city here, I live here, Jakarta. We have 270 million population. And from the data on mid-January, the number of cases confirmed positive is almost 1 million, and now today is already surpassed the 1 million. And this the number of death case, fatal case, is almost 30,000. From this diagram, we can see that the number of these cases from the first case found in March, the beginning of March last year, until now it's still increasing, especially the last few weeks. And this is the situation, the number of referral laboratories. When it started in March, we have only 12 laboratories doing the PCR test. But now, fortunately, now already 570 labs. And this diagram, we can see that now we can reach the target from, according to the WHO, that Indonesia, with the population, should have 40,000 tests per day. And now, last month, it's already achieved, fortunately. Now I come to the main parts of my talks. We know that laboratory tests can be differentiated between the non-specific, like this test, which will change according to SARS-CoV-2 virus, but also to others viruses, bacteria, or other condition. And we have specific tests for the presence of SARS-CoV-2 virus. And this can also further differentiated between the direct, to detect the presence of virus or the part of the virus, and indirect tests that detect the specific immune reaction from the body of patient against SARS-CoV-2 virus. The diagnosis of COVID-19, we know that it's also similar with diagnosis of other diseases. That means, based on comprehensive results of the clinical examination and diagnostic laboratory and radiology. Now, my part is to talk about that laboratory diagnostic. Here we can see that from the patient, we can take either swab, nasopharyngeal swab, or oropharyngeal swab, and blood. From the swab, we can get the virus or parts of the virus can be detected by the nucleic acid amplification tests or antigen. And from the blood, we can test the antibodies. And here is also more detail. From the molecular test, we can do isolation of the virus, RT-PCR, rapid nucleic acid amplification test. And from the viral protein, by seroimmunology, we can detect the antigen. And from the host protein, we check the antibody. I will concentrate on this, focus on this test. If we compare these methods, then we will see that the most reliable and high accurate is the isolation, and antibody is the weakest. But if we see the cost and the easiness, isolation is the most difficult and antibody is the most easiest. Here, of course, we should select the right test, which is in the right time. And here we see, during the virus entry to the appearance of symptoms, which is called incubation period, we couldn't detect of the virus because the virus needs to grow first. From the virus, this we can check the protein antigen, and from the RNA, we can do the nucleic acid amplification test. This is the first step to get the samples, specimens, doing the naso and oropharyngeal swab. And the swab and the viral transport media is very critical. Also, the technique and skill to get the specimen, because these factors can affect the results. And we need also cold chain. As the gold standard, actually that should be the isolation or culture of the virus. However, because of the limited facility is less available, now we use the nucleic acid amplification test as the gold standard. We can separate between the RT-PCR, excuse me, this is false, typical false, and rapid and AAT. Here you see the virus. From the virus, we can see there are many parts with the many genes. Spike, membrane, envelope, nucleocapsid. The RT-PCR detects target genes. There are several target genes. The good method should detect at least two genes, two target genes. We know that in the amplification cycles, with the changing of some temperatures, incubation, then we can amplify the number of the virus from 1 to 2. If 10 time cycles, then become 1,000, 1 million, 1 billion, and 1 trillion if it's 40 cycles. Here we can see the graph. The cycles, if the viral load is high, then the CT value will be low. So the CT value is reciprocal with the viral load. Usually we use cutoff for the CT values at 40. That means CT above 40 we consider as negative, and CT 40 or less we consider as positive. If we compare between the real-time reverse transcriptase polymerase chain reaction and rapid NIT, then we can see that for the RT-PCR, there are many steps. So the analytical time is long enough, 3 to 5 hours per run. In the rapid NAT, they make it simple in the form of cartridge or just use one temperature, isothermal method. The analytical time becomes 1 or 2 hours only per run, but however, usually the rapid NAT test less than 12 samples per run or less. So the rapid NAT is alternative for RT-PCR. Here I would like to show that the diagram. Here we can see the virus, the red circle, and the yellow is the genetic material. In the early acute phase, the RT-PCR result is usually positive because the viral load is high. But La Scola et al. Has shown the viral load will decrease by the time. And so in the late acute phase, the swab can give negative or positive before. Now we talk about the antigen. We see that antigen tests, there are two rapid diagnostic test antigen. There is naked eyes, the immunochromatographic method. But we have also another POCT by using the fluorescence immunoassay and the result read by optic reader. It's concluded that read by optic reader is better than visually by eyes. There are comparison table later on. So if we compare antigen test and NAAT, we can see that for the sensitivity, antigen test is moderate. In antigen test, there is no amplification. That's why more false negative in this method. However, it's easy to perform, can be used outside of laboratory, very flexible, and the short time for the analytical time only less than 30 minutes, while NAT needs 3 to 5 hours, and it's more economic. If we see the advantages and disadvantages of the advantages is, as already mentioned, don't need special level of biosafety laboratory. Good for the load is still high in the test. But however, of course, they have also disadvantages that the skill of the swabbers will affect the results. And variable sensitivity. That's why we have to do the preliminary certain diagnostics. The immunochromatography method has advantages as the short reaction time, simple and comfortable, can be read by naked eye. But however, it has the result often is false negative, and by read by eyes, some full results. Now I would like to compare between the antigen tests, between the rapid and POC methods. The rapid test and POC method, same target, But here you can see compare reading by naked eyes compared by optic reader. The result record will be done manually, but using the POC, we can, by system, we can have the printout SD card and can be connected to LIS. And then also we can use internal and external control. Here is once again comparison between rapid without reader and POC with optic reader. Both are mobile, but here is without connectivity, but using the optic reader, we will have connectivity. And connectivity means that we can do the QC better, documentation and billing. And according to this one study in the South Africa, they mentioned that test by POC read by optic will give better sensitivity compared than read by eyes. Here is the one of brand of the POC COVID antigen, iChroma 2. This is the method, and this is the analyzer with optical reader and connectivity. And I would like to show the result, the preliminary test in the Indonesian Department of Health R&D laboratory. We call it here the Indonesian National Institute of Health Laboratory. This was done last November. This is only small scale. We use samples from the RT-PCR positive. We differentiate it according to the level of the CT value, and we also test some negative. The results showed that up to CT 30, there is a 100% accordance between RT-PCR and iChroma. So the sensitivity is 100% for CT value 30 or less. For the CT value above 30 to 40, the sensitivity is lower at 20%. CT is 100%. We know that every test, laboratory test, has three aspects: cost, time, and quality. And also, government was asked which method is the best choice. Of course, they will see first, cost should be low, time should be fast. So, how about the quality? Could we sacrifice the quality because of the first two factors? Of course not. Yeah, we should use a valid treatment. And then, according to WHO, the requirements for every test is sensitivity should be above 80% and specificity above 97%. Compare the test with the reference molecular RT-PCR method. And we see that the iChroma antigen test can fulfill the requirements. Now I would like to show this. We can see that here, the course of the COVID infection, first the incubation, then the last 2-3 days before the symptom appear, we call it the pre-symptomatic phase. Then the first week is the early acute phase, symptomatic. Then followed by the middle acute phase, late acute phase. In this slide, I would like to show the right test at the right time based on the previous slides. Here we can see that during the incubation period, we couldn't detect the virus. But at the late phase, the pre-symptomatic, 2-3 days before the symptoms appear, we can test the virus by using the RT-PCR or rapid NAT, and also the antigen test. Here we can see. Then during the early acute phase, this still both tests can be done. According to WHO recommendation, antigen tests could be recommended for 2-3 days before the symptoms appear and 5 to 7 days after symptoms. And then in the middle acute phase, we see that antibody already developed, can be detected, first IgM and later IgG. Then in the late acute phase, the RT-PCR may be already negative. Also, antigen is earlier negative. IgM may be plus or may be negative, but IgG is more higher. And in the convalescence and recovery, we can see the anti-IgG, anti-SARS-CoV-2 only. So I come to the summary of my talks. To detect the SARS-CoV-2 virus, there are many tests. We can differentiate between nucleic acid amplification test and antigen for detection of the virus or the parts of the virus, and antibodies for detection of immune response to the virus. The gold standard is routinely we use the RT-PCR, rapid NAT and antigen tests are alternative methods in situation with no available RT-PCR or less available RT-PCR. Their sensitivity are lower than the RT-PCR, so it's best to use it when the viral load is high. So 2-3 days before the symptoms appear, or in case of contact person, on the day 5th usually, and 5 to 7 days after the symptoms appear. For rapid antigen tests, it's recommended to use method with optical reader and connectivity, of course. So, because there are so many tests, we should select the right test at the right time. Thank you very much.
Thank you. Thank you very much. Thank you very much, Professor Masuki Surya Major, for sharing that you are the long years experience working in the clinical pathology and the immunology. It is very much encouraging to everyone the listenings from you. So even though we have many different platforms to the testing of the SARS-CoV-2, still now the real-time PCR, reverse transcriptase real-time PCR, it is the best method and it is a choice method and it is still the gold standard. However, for the COVID-19 pandemic, it is hitting no sparing of the poor or the rich countries. So for the developing countries like the Myanmar and the countries that still RT-PCR facilities cannot reach up to the grassroots level. And also the far and the remote area, they have the very much difficulties to transfer and transport those samples coming to the reference laboratory. Currently in Myanmar, it is 41 to 43 now coming in through this around the 45 numbers of the RT-PCR laboratories. However, still some remote areas they cannot reach to the RT-PCR laboratory within a short period with the good quality of the samples integrity. So in this regard, rapid diagnostic tests are now widely used, especially in the who are traveling from the one cities to the one city. So it is less sensitive in the asymptomatic patients. However, everyone knows that in 65 to 70% of the COVID-19s are asymptomatic. So by this rapid diagnostic testing can elicit the SAM's hidden positivity. Nowadays, Myanmar, it is the high prevalence regions. So in that regards, rapid diagnostic test, it is still crucial. So you here highlighted well that it is the better way, it is to use the optic reader and more than the naked eye. So in this regard, in body tech, it is now body tech Korea. It is now they are the manufacturing the connectivity, high connectivity optic reader like the Anchromarks or FES. We wish to welcome that. And also the this body tech has also developing the many products for the in vitro diagnosis and the diagnostic reagents for more than 20 years. So the on-site diagnosis as well as the ICT and as well as the like optic reader are very much well used in the countries. So thank you very much, Body Tech, again for the introducing that this kind of the optic readers coming to our field. So again, thank you, Professor Masuki, for sharing of your world experience laboratory diagnosis platform. So thank you very much. So last speaker is Professor Momo-san. So she is from Myanmar. She is the professor and head of the Department of the Tropical and Infectious Disease in the University of Medicine, Yangon. And also she is doing the co-joint or the major, her role is now in the leading physician as the professor and head of the one specialist hospital. We call it the South Oklahoma Hospital. This hospital, it is a COVID-19 designated hospital, second hospital PR in country. She received her business medical degree MBBS in 1990, and then she finished the Master of the Internal Medical Science and Med Science in 1998. And also she finished the Doctorate of the Medical Science and also the Diploma of the Medical Education. She achieved the fellowship of the Royal College of the Physicians of the Edinburgh FRCB in 2014. After that, she served for the country. Before that time, that she traveling, working as a public health servants across the country in the states and region, even in the remote area. She is a member of the Curriculum Review Committee at the University of Medicine, Yangon. And also, she is now taken as the professor and head of the tropical and infectious disease in the University of Medicine in 2016, now 5 years duration. She has been assigned to serve as the leading physician in this newly established COVID-19 designated hospital. She has been the contributor in the development of the clinical management guideline, and also same time that she is sharing her teaching capacity building activities of all the nurses and also the medical orienters and as well as the medical professionals. So I would like to request Professor Mumu-san to start the presentations. Thank you very much.
Thank you, Madam Chair, Professor Mamato Tititin, for a kind introduction. Good morning, all the speakers and the audience. I would like to say thank you for allowing me to participate in that webinar. Let me share my slide. This morning, I will going to discuss about the clinical perspective of COVID-19 in Myanmar. This is my outline of presentations. Let me start with the clinical manifestations. As you all know, fever is the most common clinical manifestation, followed by the respiratory symptoms. And then some severe patients may present with the dyspnea, chest pain, and a shortness of breath. These three clinical manifestations indicate that patient has the severe disease, and some may present with the GI manifestations like anorexia, nausea, vomiting, and diarrhea. And some may have some fatigue and the muscle aches and pain. The incubation period is between 2 to 14 days, and then most of the patients, 81%, may have a mild to moderate symptoms. They don't need any active medical treatment. But 14% of the patients have a severe category and they need active management. And 5% of the affected population, they have a critical illnesses. These are the severe manifestations of COVID-19 diseases, neurological disorders like the confusions and acute stroke and hyperinflammations and acute respiratory distress syndrome. It is one of the most common cause of death in the COVID-19 severe diseases, and cardiac dysfunction like the myocarditis and acute coronary syndrome, and hypercoagulability like the acute arterial and venous thrombosis and acute kidney injury. All these are the common in the adult population, but in for children, multi-system inflammatory syndrome is can be seen in the children around the world. Although the most of the patients mild to moderate effective, but all age and any age with a certain underlying medical condition like diabetes, hypertension, chronic respiratory, cardiac, renal, liver diseases, and the some patient with the underlying immunocompromised stage, they are at increased risk for severe COVID-19. Let me discuss about the some Myanmar data. In Myanmar, positive rate is 6.2%, and the case fatality rate is about 2.2% right now, and nearly 88% of the patients are recovered from acute illnesses. This slide shows the epidemic curve of COVID-19 cases in Myanmar. In second wave, most of the patients are from local transmission. In first wave of the illness, most positive cases are imported from the foreign country. This is a slide show the confirmed case and death by epidemiological week. And this is trend of positive rate for COVID-19 testing. We can see that in right now, our country is decreasing trend. This is a test and positivity rate. The highest positivity rate, 33.2%, is found in from the PUI group. This is an analysis of age group and gender distributions, and each and every age group gender distributions is more or less the same. This is a symptoms of confirmed case at time of reporting around the country. You can see in half of the mid of the since mid of the August, the anosmia is the most common manifestation in our country. This is a type of underlying disease among the confirmed case. Diabetes and the hypertension are the two most common cause of comorbid disease in COVID-19 confirmed cases. This is a CFR by age group. The highest CFR is seen in the elderly people aged more than 75 years old, which was 20.7% of CFR. This is a proportions of comorbid patient among COVID-19 death. 85% of the expired patient, they have one or more comorbid disease. This is an underlying comorbid condition in expired patients. You can see hypertension and diabetes is the most common comorbid disease in expired cases. Let me discuss about the SOSH data. The SOSH is open on since 18th of April as a second designated hospital for COVID-19 care in Yangon. About 710 patients admitted to SOSH. Since April to 31st of December, in first wave, 124 patients admitted, and second wave, 86 patients admitted to SOSH. In first wave, mortality rate is only 1%. In second wave, it's 8% mortality in SOSH. This is an age distribution. In second wave, not only the young people, but also middle-aged and old-age people are admitted to SOSH because of the local transmission, and the elderly patients with comorbidity, they are prone to get the infections. This is the symptoms. In first wave, 40% of the patients are asymptomatic, but in second wave, only 13% are asymptomatic. This is the presenting symptoms of the COVID-19. Compared to first wave and second wave, the presenting symptoms are more or less the same. The most common one is a fever and the cough. This is a comorbid condition. In second wave, 50% of the admitted patients, they have one or more comorbid conditions. This is a severity. In first wave, most of the admitted patients are mild to moderate severity, but in second wave, the severe category found in 35% of the patients, and critical illness are found in 9% of the admitted patients. This is a complication. In second wave, almost all varieties of the complication we can see. The most common one is ARDS and followed by the cardiac complications. Let me discuss about the some cases admitted to our hospital. The first case is 20-year-old man presenting with a 2 days history of cough. He has no remarkable past medical illnesses, and he has no respiratory illnesses and no hypoxia. These X-ray and the laboratory parameter all are within normal limit. And on 11 days of hospitalization, after isolation period, he can be discharged without any complication. So the young people who have no comorbidity, they don't need to treat any active treatment, and then they have no complications. Second case is a 46-year-old woman presenting with a 7 days history of fever and cough and 2 days history of dyspnea. He has a slight respiratory distress with the SpO2 of 91%, and cardiac status is stable. And this is an X-ray and laboratory parameter of that lady. She has been treated with the dexamethasone and the remdesivir. After active treatment, her parameter getting better, and she can be discharged 18 days of hospitalization without any complication. So middle-aged patient, although they have a severe disease, and they can be recovered without complications. Third case is the 54 years old woman presenting with a 10 days history of cough and 2 days history of dyspnea. When she arrived to hospital, she is very ill. She has respiratory distress with SpO2 of 91% on air. 1 day after admission to isolation ward, her hypoxia is getting worse. So she was transferred to the ICU to get the ICU care. These are the X-ray and laboratory parameter of that lady, and the acute absolute lymphocyte count is 1.3 and CRP is 136 at the time of admission. She's been treated with a Dexa, remdesivir, and 2 units of convalescent plasma. She made her recovery within the hospital stay, and she can be discharged 19 days of hospitalization without any complication. In that lady is a middle age. She has a very severe disease, and she have a two comorbid condition, but she can she is recovered because of the just in time arrived to hospitals. Case 4 is the 88 years old senior citizen admitted to SOSH, complained of the 6-day history of fever and cough and 3 days history of dyspnea. He has a hypertension, ischemic heart disease, and atrial fibrillation as comorbid condition. On arrival, is really ill and respiratory distress and SpO2 of only 71%. So he need a ICU care. This is an X-ray and laboratory parameter of that senior citizen. X-ray is severely involved, and absolute lymphocyte count is only 0.4 and CRP is 164. He was treated with the dexamethasone, remdesivir, and the 3 unit of plasma, which all started at 6 days of illnesses. And he needed 37 days of hospitalization because of his underlying cardiac condition. And we have to struggle with the atrial flutter and the arrhythmia, and we need a cardiologist input, and then he need a DC cardioversion. At the end, he can be discharged after 37 days of hospitalization. Now he can stay with off oxygen and he is mobilized at home. That the senior citizen is 88-year-old. He has an underlying condition. His condition is critically ill, but we can save him because of the in-time management. Case 5 is a 42 years old, presenting with a 12 days history of fever, 11 days history of cough, and 4-day history of dyspnea. He has no remarkable medical problem previously. On arrival, he is really critically ill, restless, and then respiratory distress and SpO2 of only 64%. When this is an X-ray, almost all lungs are effective, and the prognosis parameter are severely deranged, and he needed intubation. When he arrived to hospital, 2 hours after intubation, he was passed away because of his severe respiratory distress and bradycardia. Although he is only 47 years and no remarkable underlying comorbid condition, we can't save him because of the late arrival. Case 6 is an 85-year-old woman presenting with a 7 days history of fever and 7 days history of cough and 3 days history of dyspnea. No significant past medical history. When she arrived to hospital, she is ill, restless, and marked hypoxia, SpO2 of 84%, and she needed ICU care. The laboratory prognosis parameter, you can see, is not improved at all. And this is an X-ray of that lady, and she arrived to hospital on 7 days of illnesses, and she's been treated with the all-out treatment, oxygen, Dexa, remdesivir, and convalescent plasma. 2 days after admission, her hypoxia is getting worse, so she need to treat with HFNC, high flow oxygen, and 2 weeks after admission, he need intubation, and we try our best, but 2 weeks after intubation, just expire because of the ARDS and then the complications. In our country, for clinical management guideline, MOHs first distributed to whole country since 3rd of February. Based on the new finding and the available therapeutic tools, we update up to the version 5, and version 9 is just ready to disseminate to the whole country. In our guideline, they clearly mentioned that mild, moderate, severe, and critical. Active management and is only needed for the severe diseases and the critical cases. Mild and moderate cases, we need to monitor, but not need any active management. In our guideline, we clearly mentioned that it is what is the indications for dexamethasone therapy. It's only recommended for the severe illnesses with SpO2 of less than 94% and 6 milligram IV or per oral for duration for 7 to 10 days, and only should not be used for either preventive or treatment of mild to moderate COVID-19 disease. In our guideline also include investigation treatment like the remdesivir and the convalescent plasma as well. As you all know, oxygen is vital for management of hypoxemic patient. With low flow to high flow, titrate with the patient's requirement. Not only the oxygen, but also the awake proning position may reduce the ICU admission. So we currently practice the awake proning position to encourage our patients to practice 4 hour proning and 1 hour comfort break. It is useful for severe cases. In Myanmar guideline, and first we start to use remdesivir since 25th of September, and we put on the SOP for usage of remdesivir because remdesivir is an investigational treatment. So this is a eligible criteria for remdesivir usage: 18 years and above, who has symptom onset within 10 days, and on X-ray, pulmonary infiltrate, or patient has a hypoxemia less than 94% on air and need oxygen supplementation, and whether patient has no contraindication for remdesivir like EGFR less than 30 and liver function, liver enzyme, ALT, AST more than 5.4 above the normal. These are the contraindication. So this slide shows dexamethasone usage among COVID-19 in SOS stage. In second wave, nearly 50% of the patient need to treat with dexamethasone, and this is a remdesivir usage. And since 25th of September up to 31st of December, 194 patients, 43% of admitted patients are eligible to use remdesivir in SOS stage. This is an outcome. 11% mortality in remdesivir use patient, and 75% recover. This is the effect of remdesivir on prognosis parameter. You can see all the prognosis parameter: absolute lymphocyte count, CRP, LDH, and D-dimer, all are improved after the remdesivir. Another treatment option the patient can get in Myanmar is convalescent plasma. In SOS stage, we start to use convalescent plasma on 4th of September up to 31st. 1 to 2 patients, 23% of admitted patients are treated with the convalescent plasma. This is an outcome: 54% recover and 25% mortality rate. This is the effect of convalescent plasma. All the prognosis parameter are improved by convalescent plasma treatment. Another thing is prevention of thromboembolism. As you all know, thromboembolic complication is not rare in COVID. So in our guideline, we consider low molecular weight heparin 0.4 milligram. That is a prophylaxis dose for every critically hospitalized patient to prevent the thromboembolic complication. Based on our the clinical experience in Myanmar, I would like to present the key reflection. Infection prevention and control measures are essential in every step and every point in time. Team leads should consider caring for team member, prevention of infection, sustaining the well-being, stamina, and motivation, which enhancing the mutual trust and positive environment. Cooperations and coordinations are vital between the clinicians and other caregivers, between the administrators and service provider, between the implementer and policymaker, patients and healthcare providers. Situations on the ground should be monitored continuously to optimize available resources, to be responsive to the needs and the change, and to aim for the best possible outcome. Course of the disease is still a challenge to predict, so we need support from laboratory, imaging, and other assistance essential. COVID-19 disease is, we don't know the exact course of the COVID-19. So we are still learning from the both local and global experiences. Sun cannot be safe despite all out effort I previously discussed in case series, and not everyone needs all therapy. Only severe cases need the active management. Elderly and those with the comorbidity have a higher morbidity and mortality, so we need to save that vulnerable population. We need to protect that vulnerable population. Timing is key in treatment. For example, dexamethasone when in need of oxygen, and remdesivir in the within 10 days of symptom onset, because remdesivir is an antiviral and it can affect in early phase, and convalescent plasma within the 2 weeks, and monitoring of the changes and timely resources are responsive are vital. So involvement of the patients in monitoring is important. It's essential. COVID can affect the multi-system, not just the lung. So we need a different specialist input. So multidisciplinary approach is essential in management of COVID-19. Safety is essential for provider as well as the patient. So we need a hospital and isolation ward layout for the prevention of the disease transmission. And prevention is better than cure with this one. So we have to practice preventive measure like wearing of the mask, practicing social distancing, hand washing, and avoidance of the overcrowded area. Thank you for your kind attention.
Thank you. Thank you very much. Thank you very much, Professor Umu Sens, for your very much anonymous knowledge and well working experience based on your the daily practice and sharing the best managements to our very pitied sufferings patients with comorbidities, and as well as you have the very good experience in the COVID convalescent plasma, and as well as the some likelihood of the second time or reinfections with the gene next generation sequencing report as well. So thank you very much. I expect in all panelists and as well as the all audience could have the very tasteful knowledge hearing from the professors Momo Sens. Thank you very much again. So here is the last speaker. The last speaker, but not the least, I would like to introduce Dr. Donabel Tuberer from Philippines. She is very looking very young and very active. She has a good professional education, studying as a biologist from the University of the Philippines, and finished the Doctor of Medicine from the St. Louis University. And also she finished the master degree for public health and the international health diploma holder. And also now she is now ongoing the courses for the master for the international health. And as well, she published several publications in peer review journal like an Asian Pacific Journal of the Tropical Diseases and the Journal of the Negative Results in Biomedicine about dengue infections in our environment in the Philippines, and as well as the epidemiological investigation of the measles in the Baguio city. And also that she can publish the paper related to the TB registry, and also the environmental paper like the weather conditions and the study on the violence against a woman. So she has the wide knowledge more on the public health and epidemiological profile. It's very impressive. And also she has now working as a medical officer for, and also she previous positions and appointments as the resident physicians and lecturer, and as well the visiting faculty in the St. Louis University Graduate School program from 2010 until present time. And also she achieved many trainings, mainly major areas are epidemiology, surveillance and disaster management, and tobacco control program, tuberculosis control program, and as well in other trainings like dengue prevention, and also the health workshop, investment planning, and private partnership for the health task force, and also the electronic free health services information system. It's quite impressive in the public health area. So we all expect to hear more epidemiological point of view from the current COVID-19 pandemic. So without delay more, I would like to invite Dr. Donovan for sharing the PowerPoint presentations. Thank you very much.
Thank you, Professor Tataitin. And it's indeed a privilege to be part of this prestigious event. And I would like to thank the organizers for inviting me to this activity, the topic closest to my heart, which is public health. So it is a pleasure to be sharing with you our experiences and best practices before an international audience of policymakers, medical practitioners, and the media. This presentation provides a snapshot of how urban areas like Baguio City can provide a challenging environment, especially in such a time as this pandemic, and how we manage and overcome these challenges. This is the latest post by the World Health Organization, and we already surpassed in the Western Pacific region more than 1.3 million COVID-19 cases. Nevertheless, the Western Pacific region and the Southeast Asian region would still contribute to about 14 million of those cases. In a snapshot, this is the latest January 29 cases of the ASEAN region, with Indonesia having the most number, Philippines number 2, Malaysia number 3, number 4 Myanmar, Singapore at number 5, and so on and so forth. And in the ASEAN region, we already almost have more than 2 million of confirmed cases, of which 44,000 have already died. In the Philippines, this is where we are located. Our city, which is found here up the north, is a landlocked city with a land area of 57.49 square kilometers up in the mountains of the Cordillera, with an average elevation of 1.4 meters above sea level, of which you can see pine trees at my back. As of 2020, we have a population of 370,000 and a growth rate of 1.54% and a population density of 6,386 per square kilometer. So this is the city, a highly urbanized city, and it is the center for regional and local administration, education, health services, trade and industry, and the summer capital of the Philippines, as well as the gateway of the Northern Cordillera provinces. This was the latest post visit of the World Health Organization in our city, and we are being held and being said by the WHO as the model for contact tracing and COVID-19 response in the Philippines. You can see here, this is our contact tracing operation center with our mayor there. That's me. This is the WHO director and some members of the Department of Health. We are showing here the different strategies with regards to contact tracing. Our city, like any other cities worldwide, had been battling with this COVID-19 response since the onset 11 months ago. And what we did was to make things transparent to the people because we believe That's a good governance means transparency. So you can see in our website different um, data on how people would know the current situation in our city. So here you can see the latest as of last night, a total of 4,912 confirmed cases and a recovery rate of 87%. And we have the lowest in the region, in the whole country, of in terms of case fatality rate. On the extreme right, you can see the heat maps where we can see all the cases across the villages in terms of the number of cases. What you can see here is the National Action Plan framework that the national government has formulated for us across the Philippines to adopt. It is in this form: prevent, detect, isolate, treat, and reintegrate. This is at the national level. And under each of these are key result areas where this has to be implemented at the local area. So this is our framework, the National Action Plan Phase 2 framework for the city of Baguio. So we also follow the P, prevent, detect, isolate, treat, and reintegrate framework in terms of our response to the COVID-19. This is a plot of the daily projected COVID-19 cases before, starting from March 23 onwards. We started easing restrictions back then in order to adapt to the different uh, challenges that the city has faced. What you can see here, the red upward graph indicates the projected cases without intervention, and the blue line shows the number of actual daily cases. The blue line is a plot of the effectivity of the implementation of the targeted actions that are embodied in the city's PDI strategy. On a do-nothing scenario, as of January 26, the number of individuals should have been 54,041, but we have prevented a total of 49,183 because of the different actions that we have taken. Comparable with the hammer and the dance theory propounded by Thomas Puyo, at each peak of the blue curve, we drop quick and aggressive area-specific controls or hammers, which resulted to the valleys or dips in the curve. It is indeed a dance, a complex dance of measures to getting our economy slowly back on track while keeping our citizens safe from the virus, lower the infection rate, and avoid the overwhelming healthcare capacity. The healthcare carrying capacity sets the limit to our decisions. It is a guide for the expansion and integration of all health services and infrastructure in order to provide a wider latitude of freedom for eventuality of widespread infection, or to be ready for the possible consequences now that we are implementing a slow, safe, and sure reopening of our economic activities. And we have established 8 trigger and response algorithms, which guides our calibrated response to COVID-19. This whole of government responses is influenced by our mission of mitigating the impact of the pandemic on the health of our citizens, to enable us to function normally as a community as much as possible, and to minimize the economic consequences of the pandemic, and to plot our recovery by a greener or healthier urban agenda. Since the start of our community quarantine in the islands of Luzon, the city had been executing an iterative response to COVID-19. We are implementing a top-down, side-to-side, and bottoms-up approach. Communication and information dissemination to the entire community from the executive levels of the local government to the villages and to every citizen had always been our paramount objectives. We have established and still are exploiting effective platforms of communication as it is imperative that information as to progress of the pandemic, our contact tracing efforts, as well as other orders and instructions on health and safety and the calibrated opening of business and economy in the city is brought down to the people at all times. We have set our actions that would get COVID-19 related messages through the public effectively at the right time. It is only through this means would we be able to enforce necessary safeguards and controls to curb the onslaught of the virus in our city and to our people. A risk communication plan are in place and are already being distributed in the public. The engagement of the target audience is a paramount step in the plan. We put a premium to feedback mechanism so that we, decision makers, are likewise in the know of how the citizens are coping so that we can respond to their concerns and requests in real time and adjust our decisions whenever it is deemed necessary. Our leadership has been vocal and consistent to the mission of transparency and good governance and leadership across all levels, as well as the private sector. This would only be the only way that we achieve a whole of society approach in battling this disease. At the moment, the PDITR strategy is a guide to managing our decisions responses. Considering the complexity of the urban environment, we had to develop activities that in most cases creative in nature with proper consideration to the context of the place and the people to which the solutions are directed to. The city has put in place prevention activities through constant disinfection, imposition of non-pharmaceutical solutions such as social distancing, hand washing, and constant cleaning of surroundings. A centralized triage serves as our gateway of sorting our locals, visitors, and returning residents before they are permitted to join the general population. Contactless and cashless payments, especially for users of public utility vehicles, are also being put into place now and is expanding to other transactions, including transactions in the market as well. Prevention strategies are constantly being communicated. We can say that measures aside from regular health screening, controls on circulation, as well as occupancy limits are being made as an integral part not only for our consciousness and behavioral system, but in our evolving urban plans and strategies. The city's contact tracing strategy remains to be the most effective method in the containment of outbreaks and in detecting and tracing cases that are immediately tested and isolated. We now have a total of 40 teams and 1,006 members, making up our well-trained, multi-specialist contact tracing team with an efficiency ratio of 1 case is to 37 close contact, and technology tools and data analytics for intelligence gathering, surveillance, real-time monitoring, and this deployment of resources, as well as planning and predicting for future eventualities are our main component. The city is now an incubator, a testing ground of innovation and technology solutions. There is no doubt that technology will drive the search for solutions to combat COVID-19 as well. We have done a series of pilot testing of antigen use in the city in terms of the use of antigen testing among travelers and the use of antigen testing among close contacts. The result of our local testing has been adopted by the national government in terms of policy formulation. And we are grateful that the city has making an impact in our nation. Corollary to the present cumulative 875 beds in our isolation facilities, residences, apartment buildings, dormitories, as well as hotels are constantly being assessed and deployed as our quarantine facilities for the well and isolation for the sick. Contact tracing findings has been afforded the identification of hot zones in several residential and commercial areas around the city, which were placed under active containment. Assistance on essential items were provided to the residents and who were placed on hard lockdown. Treatment protocols in the city's 6 hospitals starts with triaging and an online referral system. And afterwards, they are admitted and are managed according to the clinical presentation, progression, and risk factor. Getting discharged is a happy event, but the assistance continues on to recovered patients, especially on their mental well-being and into their whole well-being as well. Telephone calls and home visits are also done regularly to check on how they are doing and how well they are reintegrating. Our next hour would be the reopening of the economy. And we have plotted our strategies on how we can reopen our economy by coming up with a recovery plan. We have allotted 100 million pesos for the Baguio's revitalization action for vibrant economy. This is an economic stimulus package with zero interest for the assistance of MSME. And we have been recognized as the 2020's most business friendly local government unit award by the Philippine Chamber of Commerce and Industry just recently. Our second additional R is the road to city smarthood. Even with the setbacks brought about by the pandemic, the city gathered more resolve to become the smart city by 2022. We are currently developing the Smart City Command Center worth 200 million pesos right now, and it is actively engaging the stakeholders and technology partners to put flesh into this digital platform. With the pandemic, connectivity has become an imperative. Thus, it is entered into a memorandum of agreement to various government agencies. This slide will show us while we have been placing a lot of protections for our citizen, there has to be what we call a multiple layers to improve our success in this pandemic. While testing will become, as mentioned by our previous speakers, testing can miss a lot of cases, and some would really not obey some laws in the city, not wearing masks, and some of them have lapses in their infection control. We have to make sure that there are layers of protection, both personal and a shared responsibility. And this is how we do the different layers of protection as I end my slides. Triaging is one of our best practice. Triaging separates the sick and not sick. It also separates who are the people who gets infected and who are the people who gets infected but are asymptomatic. And we can also see in this triaging how people get tested positive, uh, get tested positive and are detected at the triage. At this point, we saw how important a rapid test is in terms of our detection at the triage system, such that a health assessment coupled with a personal health declaration form, a medical certificate complemented by the testing would help us screen both our travelers going into the city at the same time our returning resident going into the city. As such, we have formulated already a system, a clinical pathway for this patient, such that when they get tested positive, they will be part of the health system including the information that's system that we have formulated. This is how it looks like. This is our central triage. They get tested, they got screened, and are enrolled in an information system and placed in isolation and quarantine facility as needed. This is the different triage that we have set in our different health facilities and different workplaces so that we make sure that sick people will be detected immediately and are immediately contact traced. Lastly, our contact tracing, being held as the model in contact tracing by the World Health Organization. Contact tracing prevents the onward transmission of the disease by making sure that we have identified all close contacts of a confirmed cases or a suspect case even before they get tested. And once they are contact traced, they are placed in quarantine facility at a certain number of days and are later on reintegrated once the incubation period or the quarantine period is already done. In this way, we can prevent the onward transmission of disease by breaking the chain and making sure that this close contact will not be able to transmit it into the community. And through that contact tracing, how do we start this contact tracing? Contact tracing starts when somebody enters into the system either to a hospital, the patient get tested, or the laboratories being doing submitting the report of a positive case. Once results are come in, they are thrown into our 40 teams of 1,600 members contact tracing team, making sure that they are entered into this system. Lastly, these are our lessons learned. First, systems thinking. It's very important that we don't just do laboratory testing, treatment, and prevention, but we have to integrate everything. And this is systems thinking. We have to go outside of the box, making sure that all whole of government and whole of society and whole of sector approach will be coming together to work against pandemic COVID-19. Secondly is synergy. There is no monopoly in terms of expertise in COVID-19. We can partner with other sectors and come together to come up with solutions. And this is the role of synergy, complementing and coming together to solve old and new problems. Lastly is we have to be strategic. We cannot be doing things the old way because it will result to the same way. We have to do things differently so that we can achieve what we plan and we can go to places that we have planned and we have created. Everything is created twice. The only way to create our future the only way to see our future is to create it. And we are in the medical field should take the leadership because this is a health issue and all doctors across nations should come together to work against this pandemic, making sure that whole of government, whole sector, and whole of society approach are in place. Thank you very much for this time.
Thank you. Thank you very much, Dr. Donna, for your very uh, remarkable and also you are the playing as a key player role in your city. So I learned from your the presentation is that congratulations for your the cities coming to resuming the normal travel and the normal tourism. The similarly very much congratulates your the very successful implementation of the digital transformations and the platform in the area of the contact tracing. Contact tracing is the key for the community and as well as our public health area. So contact tracing, tracking, and the testing are the key three key areas that we have to accomplish. So the similarly in Myanmar, digital-based dashboard and also daily access of the tested number, quarantine number, isolated and the confirmed laboratory confirmed cases, and the death through rate can be easily accessed in the Ministry of Health and Sport webpage, Myanmar, and the Facebook. So it is a transparently we can sharing our national data to the globe, and also this is the really reflects. So the now currently the Myanmar current daily positive rate is now. Is a down descending troll up to the less than some days less than 2.5 up to the 3 and around 3 to 3.5. It is a general for over the last 2-3 weeks back ago. So this is the good sign. So our political leaders and the government leaders are now thinking of the resuming of our daily normal activities, co-living with the COVID-19. So thank you very much, Dr. Donners. You are very much impressive epidemiologist, and I wish you are the ways for you are the degree, and as well as the role of the public health will be the most successful in coming future days. So thank you again, all four speakers. We have done for the all presentations, and this is the time for the questions and answers. I have seen the several numbers of the questions in the Q&A box. So some questions are going to the directly to the Professor Mazuki. Some questions are much general. So I request Dr. Omar Sweetin from Myanmar first uh, to answer the one questions. So I'm Dr. Omar Sweetin said, can you answer the same one questions asked from the Professor Kindida from University of the Medicine one?
Hello. Regarding your questions, how methods we should proceed in future when COVID-19 infection is downstream but not eradicated. The gold standard test is the real-time RT-PCR test. It is not depending on the number of the cases increasing or the decreasing. So the standard test is not changed. So, and another is in the low prevalence time, the rapid test is not working well. Rapid antigen test is not working well. So if you suspect the COVID-19, so we need to do the gold standard is the real-time RT-PCR testing. And for the immunized persons, neutralizing antibody test should be done. Thank you, Mama.
Yes, and also she is concerned in the what kind of the laboratory test in the current area, current time, like and our Myanmar state, it is going down trending time. So that whenever we are the staying in living with co-living with the COVID-19, I think so. The general population incidence prevalence will be the more less and less. At the time, rapid diagnostic test antigen is not much valuable because the rapid diagnostic test, it is the best when the country has a high prevalence and a high prevalence setting. So at that time, RT-PCR and also the combined evaluation of our immunity by the antibody. So it will be the best combined testing strategy coming in the, I think it's the 2021, mid 2021, on the late 2021. So since other questions are going to Professor Mazuki, Professor replied that he wished to respond by in percent in the live sections. Most questions ideas they are the question needs. I would like to know that it is a role of the neutralizing antibody, because most countries are having studying the fast dose of the COVID-19 vaccines. So at that time, the role of the neutralizing antibodies, and the what time has to do the testing of the neutralizing antibody after the second, or depends on the nature of the vaccines, or what time it is the best to testing of the neutralizing antibody. So I also, when my pathologist from country asking that, it is he wish to know the LAMP, non-loop-mediated amplifications. So Professor responded to answer in live. So Professor Masuki, I would like to invite you to answer them. Thank you very much.
Yes, sorry. Thank you, Professor Taitin. I have answered some questions, and according to this question about LAM, actually I would like to answer uh, writtenly, but it's okay if it's live. The LAM, there are several LAM methods, and that belong to the rapid and AAT. So as an alternative for the RT-PCR, we have tried some brands, and our conclusion is most of the tests has sensitivity lower than RT-PCR. Some can detect up to CT value of 30, and some, the best is until 35. That's about the LAM method. About the neutralizing antibody and vaccination, we have just started our vaccination program for the last 2 weeks. And the neutralizing antibody just installed for 1 week. So we have no enough experience on this. And for the neutralizing antibody, up to now, there is only one brand. That's the Rose. Now, according to my opinion, there are several types of neutralizing antibody. From Rose that detect the spike receptor binding domain, SRBD, but it's total IG, not only IgG, but also include IgA and IgM. Other brand, but this will be maybe for another weeks to come to Indonesia, they detect just the SRBD IgG only. So we have not much experience on this yet, but the time to check the titer is, as far as I know from the literature, they recommend 2 weeks after the second vaccination to detect the peak of the titer of neutralizing antibody. Is there any other questions? Haven't answered yet?
So I think professors' answers have met the all questions asking to you. So sorry, I missed the sentence. Based upon your experience, what days have to wait for after vaccinations to evaluate the neutralizing antibody? 14 days, or is it generally it is a 7 to 14 days the antibodies are immunity for the either in the natural infections or the vaccine induced infections. Vaccine induced immunity appears 7 to 14 days, or sometimes based on the individual immunity. So for the general populations testing of the post-vaccination immunities, how many days have to wait after the finishing of the vaccinations? Professor Madhuki.
Yeah, from some literature, I read that the best time is 2 weeks after the second injection.
2 weeks after first,
Yeah,
first
after the
injection.
second, for the peak, for the result of the uh, two injections.
Second injection, 2 weeks generally.
Yeah. Now I'm doing the research from my hospital staff. There are already 300, about 300 over staff members from my hospital. We already got the vaccination. So I'm doing the research. I try to examine the titer, if possible, the pre-vaccination. But the most important is the 2 weeks after the first, and later on 2 weeks after the second. That's my plan. But so far we have used only one brand of vaccine, that's Sinovac. And the recommendation is to give injection. The second injection will be given 2 weeks after the first. Now my staff members or just got the first injection.
Yes, thank you. Thank you very much, Professor Mazuki. So I would like to ask the ones uh, comments or the experience from the Dr. Donna. So the Philippines is now going to resuming the travel and the other kind of the daily life tourisms. So the nowadays the new mutant gene, it is widely spread in the South Korea and in the Asia and the other countries like the South Africa and the United Kingdom and some European countries. So in this regards, would like to know that the current updated quarantine policy for the returnees who are coming from abroad, because in Myanmar we have changed or the amending the quarantine policy or the testing policy. Before the time that we did the 2 times testing for the returnees, the first time is for the rapid diagnostic testing, second time RT-PCR to save the RT-PCR, and as well as at the time the no new mutant gene was discovered. Nowadays that we do the two times of by real-time PCR, not by the rapid diagnostic test for the all international returnees. So even though we haven't, Myanmar has not cannot start the normal daily life of the trade and some international flight. So in this regards, what's the country Philippine practice for the international returnees for the testing strategy and the quarantine policy?
Yeah, actually, just recently, World Health Organization announced that there are already 60 flagged countries with the UK variants, and they're adding more countries with regards to the South African variant and the new emerging Brazilian variant, which we just recently been announced by WHO. So at the start on, when they flagged about 35 countries, we already set in a national policy of testing on the day of the arrival, those are testing, and on the day 5 after arrival. So upon arrival, they are tested and placed in an isolation facility. And on day 5, they get tested again. Once they get tested negative, they will be they will be sent home in their local government units, or I should say provinces, to continue on with a facility-based uh, isolation and quarantine. But in case that they have found out that they are positive for the UK variant, which as of this moment in our region, we have documented 12 patients with the UK variant, the quarantine will be as far as F2. So F2, if I may just orient you, F0 is the one positive for the COVID variant. The F1 is the one in contact with the positive for COVID variant, and the F2 is the one in contact with the F1. So quarantine will be as far as F2, and it will be a 14-day quarantine, and the reckoning time will be the last day of exposure to that person, to the F0 or to the F1. So what we did was to prepare quarantine facilities, making sure that food is available, PPEs are available. It will be manned by human resource for health, making sure that they are taken care of. And containment strategies are also in place, like locking down some communities as well. But basically, that's how there are layers of quarantine from the national as the time they reach the airport up to the time they reach home. In their provinces, there are layers of protection and quarantine that we have instituted.
Thank you, Dr. Donna. So I saw that you would like to answer us in the live sessions to the one questions about the vaccination. So can you continue it?
Yeah. Yeah, I'm a public health advocate, always been a public health advocate. And ever since the time of Edward Jenner, vaccination has decreased a lot of deaths. And we can see very obviously with measles. Now we have a new disease never been seen in books. We have never seen anything like this before, and it's killing people. More than 1 million deaths is not a hoax even. So this is something that we need to look on. Now that we have the vaccine, one of our challenges in this vaccination is demand generation. We have to create demands on how these people would like to avail of the vaccine, because there are more anti-vaxxers now than ever before. The misinfodemics is now penetrating each and every individual across all social media. And these people they are attacking on are the people who are not decisive. So once we give misinfodemics, and these people will not be getting the right information from the right people, then they get swayed and will not have the vaccine. But with regards to it, I believe that most of this vaccine will prevent severe diseases. I think that's the one that the WHO would like to say. It prevents severe disease, thus decreasing mortality. And it doesn't mean that you won't get the coronavirus disease, but it means you won't proceed into severe infection, and that would save a lot of people who are vulnerable. So that's why we're targeting the vulnerables, such as the health workers and our, as shown by the data of the Myanmar, the vulnerables are those with hypertension, with diabetes, and these people have higher chances of dying, like 20%. I saw there above 75 years old, the fatality rate is 75%. These are the very people who would need the vaccine the most. And we hope that even at the country level, we'll start already generating demands for the vaccine through various means. Risk communication has to be in place, a strategic plan for people, good communicators, making sure that all forms of media should be used, because we have still time to educate the people and making sure translate this knowledge into practice by making sure they avail of the vaccine.
Thank you very much, Dr. Donalds. You said very complete and also absolutely right answers. The we never are be down and are thinking of our protective gears. We have to keep our protective gears ever and because this nobody knows how long does it take of this pandemic after the vaccination, because nobody knows is that it can be the protective really protective antibody, or it should be injected like an influenza vaccines, and also either in the T cell mediated immunity or the B cell immunities. It is still questionable. Thank you very much for your answers. I would like to answer the one questions that asking from the Myanmar audience. The one pathologist asking that what kind of the antibody strip used when in the neutralizing antibody. Yes, the neutralizing antibody, it is even in the we says the neutralizing antibody, they have the different types of the neutralizing antibody. Basically the very perfect and the true or real neutralizing antibody should be tested in the biosafety laboratory. It is quite laborious, and also it is very much expensive to establish the biosafety laboratory. So nowadays the developers are now creating like a pseudovirus or neutralizing antibody or surrogated neutralizing antibodies together with the sometimes called the CPAS. So whenever in the nature days, whenever we go internationally or the locally travel, we have to show up our vaccination card or we have an antibody for the COVID-19. So the neutralizing antibody strip, it is not well developed in the market. However, like in body tech, in the who affairs or the affairs or like the iChromer analyzers are now body tech are now developing the neutralizing antibody for like an ELISA based, so that this technology would solve our diagnosis queries and the diagnosis solutions. And so I think so, like in kind of the point of care in ICT, like immunochromatographics or the like a laminar flow antibody, it is not would not be the working like, because the neutralizing antibody is a very specialized antibody. It is not as easy as to say it is like in just we have an immunity neutralizing antibody. However, laboratory-based, the most preferable method is a laboratory-based chemiluminescence immunoanalyzer. And is similarly, because it is more or less more than 90% more or less equitable or the compatible with the culture-based neutralizing antibody working in the BSA3. So like an ELISA-based or the E-CLIA-based, something like that, or the neutralizing antibody would be the much welcome instead of the very laminar flow like an ICT-based neutralizing antibody. So I think almost all questions we can counter respond by live. So here's Professor Mumo-san. Is there any points, because I don't see such the right questions who it is clinically related or the clinical management queries, because your the presentation, it is very clear, and all your the scenarios, it is not a story made, it is a basically that you had countered and you had win that situations by yourself, your leadership. So any clinical management additional points you would like to add in that, or you would like to share to our local audience as well international audience, Professor Mumu-san?
Thank you, Mama. Up to now, no definitive treatment for the COVID-19. All are some are the investigation treatment, like remdesivir, are no evidence based, but we have to try as a to help to combine with all these available to help our patient. Only the dexamethasone is effective for the severe cases. So we need to prevent or protect ourselves to get the disease. So prevention is better than the cure. So we need to practice all around the world. The people all around the world need to practice the preventive measure, the easy one like social distancing, avoiding of overcrowded area, wearing of masks, and the hand hygiene to prevent these new diseases. Thank you, Mama.
Thank you very much, Professor Mumu-san. You are the very clear. So generally speaking, and also the ever we are focusing on the clinical ground, no definite treatment as to save our life. It is our protect by ourselves. So thank you very much. Here, No. So our the clinical and academic session is over. So finally, before doing the conclusion of this webinar today, I would like to call upon the correspondent of the responsible person from the Bodhitech and the Hemas Mandalar, sharing his kind of the thanks and some words from him. Thank you very much.
Hello, Dr. Choi. Can you speak like the closing note about for the this event? Hello, Dr. Choi.
Let me check if Dr. Choi is still online.
Hi.
All right. Thank you. For 2.5 hours, actually, it's a very exciting session to listen what you clinicians are talking about how to solve the pandemic in this situation. I really thank you for everybody and particularly you to organize this seminar, and it was really fruitful. Okay, thank you very much. Thank you for the doctors.
Thank you, responsible, honorable gentleman from Polytech, and Sir Daniel,
Very good afternoon, everybody. Yeah. Thank all of you for the precious time. Special thanks to the Professor Dr. T, Deputy Director General from the National Lab, and then all her colleagues, Professor Mumusan, and all. Professor from all the speakers from the overseas. Special thanks for the Daniel who arranged for this event, for the very beautiful event. Also special thanks for the Bodytech who's supporting for us a lot of technical support during this pandemic period. So hopefully we will have the more academic section in the future to exchange our knowledge to be beneficial for all the parties as well as for all our people. Thank you very much.
Thank you, Mr. Somiet, for your kind words. Sir Daniel.
Thanks for everyone participating in the panel. Especially thanks to Professor Dr. T, for the Director General from the National Health Laboratory, and other speaker, Professor Mosen and Dr. Omaswitin, as well as from the Dr. Mazuki and Dr. Donovan, as well as I would like to thank PDSO and the Philippines, like the arranging for this two valuable speaker from the respective country. And I'm very thanks to Dr. Choi for yourself joining to this event. And thanks for the participant of this webinar to attending all these participants. Thanks everyone. We promised to keep such academic in the future also, and we would like to sharing, like to keep the hand also our one of the key area for sharing of this session in the future as well. Thank you very much. Thank you everyone.
Thank you, Mr. Daniel from Hemas Mandalar, Myanmar. So the time is quite comfortable for everyone. So I would like to close these sessions giving the same fruit words. So that we are now in the midst of the pandemic. So no one knows that it is how long does it take, and how can we overcome that? Is the most real believable thing? It is that we have to go live with the COVID-19. So so many things we do more for the whole country. So the first thing it is that we need to keep and we need to enhance our surveillance strategy. community-based strategy, the institution-based, and also the real-time surveillance. The surveillance would not be the late. So real-time should be the ever real-time. Surveillance should be the ever real-time. And also that we need to, everyone knows that it is 65 to 70% of the patients are asymptomatic. So nobody knows that this is patient or not. So testing, it is the no one from the testing. So testing capacity should be increased day by day, month by month, and year by year. So how to increase the testing capacity? So as I said in my opening remarks, testing procedure have been evolving from the day of the very hard to test even the one test, single test of the RT-PCR. Nowadays, rapid diagnostic test for antigen, neutralizing antibody for the specifically for the S protein, the spike protein to do the immunity, qualitative, non-quantitative, and also the combined IgG, IgM, specific for IgG, IgM, and IgG. So, and also the naked eye to Canada based or some optic reader based, and also the chemiluminescent fully automatic high throughput. So the testing strategy and the testing capacity and testing evolution is now changed. Anyway, we have to increase and expand our testing capacity. And also, we need to let more private sector involvement in our daily practice, because the government alone cannot bear this high burden. So, promoting of the private sector involvement with the strict precautions, and also the strengthening of the risk communication. So the mass campaign and the new normal life, it is important. And also the nowadays, the vaccine deployment, it is ready. So after the vaccine, no one can assure that we have already protected, because the reinfection, it is a questionable. And also we see very few cases of the reinfection after the 90 days RT-PCR becomes negative. So this is the important thing. And also the capacity building, promoting policy in all sectors, including the health sectors, and the long-term HR, human resource development, and the logistic management. It is an expand testing capacity, increasing expansion. It is easy to say, but very much expensive for the RT-PCR testing. For the Myanmar, our monthly cost is about $5 million per month to reach the WHO target for the 3.5 million testing in this year, September. So how can we get this huge amount of the budget? Country and as well as the international donor, and as well as the country ourselves has to procure the same very basic mask or the pipette or the plastic or something like that. Even the autoclave bag, it is quite expensive. Autoclavable bag, it is a very protective gears for our daily biosafety measures. So sustainable funding, it is a questionable. So I wish all Indonesian Professor Masuki, Dr. Donna, and all body tech and also honorable companies owners and the logistics professionals and everyone, all national and the international audience. I wish everyone be free from the COVID-19, and I wish to recover from this pandemic from all countries very soon. Thank you very much.
All right, thank you everybody.